All right, so digestive 3, we're going to finish off the digestive system. We'll talk about bile and pancreatic juice secretion regulation, which we talked about on Monday, but we'll bring it up again today, and you'll write out the different pathways in your lecture notes. We're going to describe the structural modifications of the small intestine that enhance digestive processes, which you are actually already familiar with. We're just going to review them again. We'll talk about the different cell types of the intestinal mucosa, major functions of the large intestine, the defecation reflex, all the enzymes involved in digestion, and the foodstuffs on which they act. List the end products for protein, fat, carbohydrate, and nucleic acid digestion, and then talk about which products are actually absorbed by the in the intestine, specifically the large intestine. And so the liver secretes bile and the pancreas secretes digestive enzymes. So we ended off with this hormone flow last time. So there is a blank set of boxes and arrows in your lecture notes to fill all of this out. So the trigger for this pathway is the chyme from the stomach entering the duodenum. So you should know what the food is called as it makes its way through your digestive tract. As it enters your mouth, it's food. As you swallow, it's a bolus. When it gets into your stomach and mixes with the gastric juice, it's chyme. Okay. Once we get to like mid to end of the small intestine where most of the water is absorbed and we go from a liquid to more of a solid, then it will become feces. Okay. But the trigger here for these pathways is that chyme enters the stomach from the duodenum, or enters from the stomach into the duodenum. And then this is going to trigger enteroendocrine cells to release intestinal gastrin. Now this part we already talked about with gastric secretion regulation. This is the part where it's a really brief trigger of stomach secretions, but then it's immediately inhibited because we are transitioning from digestion in the stomach to digestion in the intestine. So this here from the intestinal gastrin, this is a brief effect. Because again, this is a transition phase. Do you remember what we call the enteroendocrine cells that release gastrin? We give them a nickname. G cells. So these would be intestinal G cells. And so that's not the only pathway that's triggered by the chyme from the stomach entering the duodenum. It's also going to trigger a pathway with the hormone called secretin. Secretin has two targets. The first target is the pancreas, where it's going to tell the pancreas to secrete bicarbonate. Bicarbonate is a base or buffer, and it's going to neutralize the acidic chyme coming from the stomach. So we mentioned this before, that your stomach has extra mucus in it because it's so acidic. So it has extra mucus layers in order to protect the stomach wall from the acidity within the stomach. Your duodenum does not have that same protection. Okay? It has the same amount of mucus as the rest of the digestive tract. And so we need to make sure that not only are only little bits of chyme going into the duodenum at a time, but also we're neutralizing it right away so that that acidity doesn't break down the walls of the intestines. Okay, so secretin is going to trigger the pancreas to release bicarbonate to neutralize that acidic chyme. The other target for secretin is the liver, and it's going to trigger the liver to secrete bile. Bile that's not how you spell that. Bile emulsifies fat. And so what that means, it's not making fat any more simple, so it's not digesting it or chemically breaking it down. It's just taking big fat pieces and breaking it down to smaller fat pieces. It's the same molecule though, same structure, just making it into smaller pieces. The next hormone is cholecystokinin, but you can abbreviate it CCK. This hormone has three targets. It's going to target the pancreas to release the rest of its secretions, like lipases for fat, pancreatic amylase for carbohydrates, trypsin for protein. There's also other proteases that get released from the pancreas, as well as, and we'll talk about this at the very end, nucleases that break down nucleic acids as well. Another target of the cholecystokinin is the smooth muscle of the gallbladder. So it causes the gallbladder to contract so that the bile can move from the gallbladder through the cystic duct into the bile duct and eventually into the duodenum. So this action here is where cholecystokinin got its name. Cholecyst meaning gallbladder, kinin meaning movement. So it causes the movement of the gallbladder. So that was like the first action that they discovered, which is why they called it cholecystokinin. The last trigger or the last action or target of cholecystokinin is going to be the smooth muscle of the hepatopancreatic sphincter. And actually, I'm going to see if I have a picture of that so I can show you. I'll go back. Don't worry. I'll do this one. So the hepatopancreatic sphincter, well, it's right here. And so cholecystokinin will target that sphincter there to get it to relax so that all those contents can then go into the small intestine or duodenum. So relaxation of sphincter, so biopancreatic enzymes and bicarbonate are released into the duodenum. And is my head in the way? Okay. No. I'll sit down. That better? Okay. It's okay, I have a big head. It gets in the way sometimes. Yeah. Maybe I should just sit. I'll save my legs. I should be wearing compression socks, but I don't. They are very uncomfortable. I hate compression socks. I had to wear them a few summers ago because during the pandemic, I learned how to roller skate, and I'm 36 years old, and I was getting really good too. I was going to the skate parks, and it was so much fun. And then I went to the Arvin skate park, and I broke my leg. I had a comminuted fracture in my fibula, so it broke into a bunch of tiny little pieces. I have a huge plate in my leg and 10 screws. It's huge. It was a huge break. If you're interested, I'll show you pictures of my x-rays. You can see all the little tiny pieces of my bone. But after that, I had swelling for a long time, so I had to wear a compression sock, and they're just not comfortable. I don't like them at all. Swelling went down, and so I was like, I don't need it anymore, and so I stopped wearing it. What's really funny is that the top of my foot was like tingly and numb for like a good almost 2 years until I regained feeling back in my foot.
Were you scared that it was going to just stay like that forever?
I was really scared. So at first I couldn't feel anything at all. It was like my foot was just asleep. I could not feel anything. And I started feeling tingles, which was also like painful as the nerves are starting to regenerate and repair. And so I was like, okay, this is good. And so it was really weird for a while. It's just like feeling like your legs waking up, but permanently for a really long time. And then eventually it went back to normal. I still have kind of weird times where I get pain because of the shoes that I wear or if I go too hard at the gym and stuff, but it's better. I have not skated again. I've skated maybe like twice since I've broken my leg because it's traumatizing. It's scary. And I get friends saying, no, you got to come back. I'm all scared. I went back one time, and a girl while we were out there, we went to Beach Park, and a girl while we were out there, she rolled her ankle, and I was like, oh, nope, I'm done. I'm good for the day. Okay, and so when you rewatch this, you can just forward through our little story time. All right, is everybody okay here? Okay, so we're going to focus on the pancreas next and the production of bicarbonate. So sorry to tell you, we're going to do the equation again. Because we need that equation to pull the bicarbonate from the CO2 and put it into the duodenum. So we take CO2 and water. That's going to react with what is the enzyme that causes the conversion to carbonic acid? Carbonic anhydrase is going to convert that CO2 and water into carbonic acid. acids dissociate in fluid, so it's immediately going to dissociate into its parts, which is a hydrogen ion and a bicarbonate ion. And now we have that bicarbonate. We need the bicarbonate to put it into the duodenum to neutralize the acid from the chyme that came from the stomach. We are going to balance it out, and we're going to make the positive go in the opposite direction. So we're losing both a negative and a positive, so it balances it out on either side. So the hydrogen then goes to the blood, and the hydrogen is going to cause the blood to drop in pH, because that's what hydrogens do, lower pH. And so will this make the blood acidic if we add more hydrogen ions to the blood? No. Why it's not going to? If you remember from before, when we made hydrochloric acid, we had that alkaline tide, right? That temporarily raises the pH of the blood. So then when we go to the pancreas to make this bicarbonate and put the hydrogen ion into the blood, now it balances out. So it's not going to make the blood acidic. It's actually going to bring it back up to normal from that alkaline tide. So those balance each other out. So the alkaline tide raised the pH, and now these hydrogens moving to the blood are going to lower the pH back to normal. Okay. Does that make sense? Okay. And then don't forget that your blood pH should stay between a 7.35 and a 7.45. Or you can say an average of 7.4. When we get to the next unit of material, you'll learn that there are actually pH differences between arterial and venous blood. But not yet. So any questions on this?
If the parietal cells weren't able to transport the HCO3,
Then it would make it acidic, yeah. If for some reason we weren't making the hydrochloric acid and didn't have the alkaline tide, then yeah, it would make it acidic. Okay, anybody still need this up? Okay. Hey, Gordon. Morning. Ready to finish off your brain dissection? Oh, first lab didn't get to see it. Gordon dissected the brain of the pig, so he broke open the skull. You can actually see the cerebral arterial circle nice and in red, and so he wants to get the spinal cord out today. He's a scientist. He's super curious, and I let him if he wants to.
he's cool. Good for you, Gordon. Good job, Gordon.
Okay, everyone good here now? All right. So again, that hydrogens moving into the blood is only going to balance out the alkaline tide that we just did previously at the stomach. So this is why vomiting causes, or emesis causes, alkalosis. Because again, if you're vomiting and emptying the contents of your stomach, then we're just going to go through this process again to make more hydrochloric acid, and it's going to put more of the bicarbonate into the blood. Then you throw up again, empty the contents of your stomach, we need to replace it, and we're constantly putting this alkaline tide into the blood. And so what's not happening though, is we're not getting that trigger of the chyme entering the duodenum if you're continually throwing up. And so we never get this balancing out. Go back. So we never get the balancing out that occurs over here, because this whole process of putting bicarbonate into the duodenum is triggered by the chyme entering the duodenum. So we're moving the food stuff from the stomach to the duodenum, and so the pancreas and the gallbladder can do all the things in the liver that it needs to do to continue digestion in the small intestine. So if you're constantly vomiting and constantly replacing that hydrochloric acid, and that alkaline tide keeps moving bicarbonate into the blood, this part never happens. Because this part is triggered by secretin, and the release of secretin is triggered by the chyme moving into the duodenum. So if the chyme never enters the duodenum, this never happens, and you never get the balancing out that happens over here. You just get the alkaline tide from making the hydrochloric acid. So vomiting can lead to alkalosis, where the pH of the blood ends up going above that 7.45. Because again, you need this trigger of the chyme from the stomach entering the duodenum to get that bicarbonate secreted. If that never happens, the hydrogen never moves to the blood and you don't get that balancing out. And so you end up having a high pH in the blood. Everybody okay with that concept? Anybody have any questions about that? Okay. All right, so the next thing we're going to talk about is, again, when the chyme from the stomach enters the duodenum, this triggers enteroendocrine cells to release CCK, which is going to tell the pancreas to release its enzymes. So secretin causes bicarbonate to get released. CCK causes all the enzymes to get released, as well as the contracting of the smooth muscle of the gallbladder to release the bile into the duodenum, and the relaxing of the hepatopancreatic sphincter. So all of these things can move into the duodenum. But there is a clinical note on pancreatitis. So with pancreatitis, this can be caused by, it can be caused by alcoholism. Alcoholism makes the secretions of the pancreas thicker, and so it's more likely to clog up the ducts. Alcohol also makes enzymes activate earlier and can also cause cell damage. So all of these things, the thicker secretions, the early activation of enzymes, and the cell damage, it causes these enzymes to then leak out into the pancreatic tissue, and it starts eating away at the pancreas itself. So then you have damage of these pancreatic cells, you have lots of inflammation, which is pancreatitis. Another way to cause pancreatitis is through cystic fibrosis. So I know a lot of times cystic fibrosis is shown as a respiratory disorder, but cystic fibrosis affects the mucus anywhere mucus is produced. So not just in the respiratory tract, but you're also going to have thick, salty mucus in your digestive tract too, because we make mucus there as well. And so what ends up happening is that the mucus clogs up the ducts here. And so all of these secretions from the pancreas end up backing up back to the pancreas into the actual pancreatic tissue, and those enzymes start breaking away at healthy pancreatic tissue. This can also happen if a gallstone were to clog up that duct as well. Enzymes are going to backflow back into the pancreas, seep out into the pancreatic tissue, and eat away at any proteins, fats, carbohydrates, or nucleic acids that are within those cells, causing pancreatitis. Any questions about that? We can confirm that pancreatitis is present if there's amylase, or I think lipase. So this is confirmed. Ooh, I don't know how to spell presence.
P-R-E-S-E.
I do, I just for a second. Confirm with presence of amylase and or lipase in the blood. Because as these enzymes back up, they're going to actually leach into the blood as well. And so if we find amylases and lipases in the blood, which we shouldn't, then that could indicate that this person has pancreatitis. Oh yeah, so gallstones can clog up those ducts, allow enzymes to backflow into the pancreas and start eating away at pancreatic tissue. So it can be clogged by gallstones, it can be clogged by mucus, and then also alcohol makes those secretions thicker, which can also cause that backflow. All right. Another cute little cartoon about pancreatitis. But here the little baby gallbladder says, "Hi, pancreas, I make these." And it sucks it into the bile duct, and then it bursts the bile duct, and all those enzymes end up eating away at the pancreas over here. And he's like, "You like them?" He's so proud of his gallstones. And there's the inflamed pancreas over here, all mad. All right, so don't forget these structures that we talked about during the digestive anatomy lab. We have the hepatopancreatic sphincter and ampulla. The ampulla is just a bulb-like structure. That opens to the duodenum. And the sphincter is essentially a smooth, smooth muscle ring that acts as a gate between the pancreas and liver and the duodenum. And the major duodenal papilla, this is just the opening there that allows the release of those secretions into the duodenum. I think I like sitting.
Professor, do you happen to know if those energy drinks cause gallstones?
Okay. So the only thing I can think of off the top of my head, energy drinks have caffeine, which is a diuretic, which can make you dehydrated, which can make crystallizing more
Common.
common or more likely to happen. All right, so small intestine is next. We already know this. We went over this. The duodenum is the smallest part. It's less than a foot long. Your jejunum is the next largest, which is about 8 feet long or 2.5 meters. And then your ileum is the largest part, which is about 12 feet long. So altogether, your small intestines are roughly 20 feet long, which is insane to me. Insane, so you could fit 20 feet of tube inside your abdomen. Huh? Yeah. All right, so modifications of the small intestine. These are the modifications that help with surface area. So we have what are called circular folds, we have villi, and then on the individual columnar cells, we also have, what are the smaller villi called? Microvilli. And so it's going to increase surface area. So if we didn't have circular folds or the villi or microvilli, the wall of the small intestine would just be flat without those villi, and we'd have that much surface area. If we take that much area and add circular folds to it, now we have much more area for secretion and absorption. Okay? So it increases our surface area. So we can absorb more things, release more things for more effective digestion. Everybody good with that? Okay. This all should be reviewed as well. These are all modifications that are unique to the small intestine. So first we have goblet cells. What is the protein that goblet cells produce? Mucin. And mucin mixed with water makes mucus, so that's what our goblet cells are for. Then we have these specialized lymphatic capillaries here. What are those called? Lacteals. And those lacteals are for absorbing and transporting fat specifically. We're going to give them a very special name today, so it's not going to be just fat anymore. They're going to have a very specific chemical name that we'll talk about a little bit later. But lacteals are responsible for transporting fat. Then we have this brush border. So the brush border are made up of the microvilli at the very top of our simple columnar cells. and they give off a fuzzy appearance. I think that's in your lecture notes already. But if you look at underneath the microscope, if you remember back from Bio 32, those columnar cells have like a little fuzzy border at the very top. That's called the brush border. And this is where brush border enzymes are produced. And they are essentially just going to finish off the digestion. So in order to absorb anything, it needs to be in its monomeric form. So it needs to be an amino acid or a monosaccharide or a nucleotide. And then with fats, they're actually called chylomicrons. We'll talk about those later. But they need to be in their final form or their simplest form in order to be absorbed. And so these brush border enzymes do the final breaking down to make these polymers into monomers. Now, when you take medication or have treatments like chemotherapy or medications like antibiotics, radiation too, they target and disrupt epithelial cells, which these are epithelial cells here. So they can actually interrupt the brush border physiology here. And so it can mess up with the secretion of these enzymes, which is why with antibiotics, with chemotherapy, with radiation, you can get a lot of symptoms like nausea and vomiting and diarrhea, because now this part that does that final digestion is being interrupted or targeted by those different treatments and medications. And so you don't get the final bits of digestion that you need to absorb the foods that you need. And so that's what causes all of these digestive symptoms. You can see that this is the microvilli. That would be the brush border. You cannot see the brush border that clearly underneath the microscope that we have. You would need like a really high, like an electron microscope you would need. Very, very high magnification. But that's what it would look like. Any questions about these modifications? These are all unique to the small intestine compared to the rest of the GI tract. Okay. So this is what I was telling you before. So I don't know if you can tell, but there's like a dark pink line at the very top compared to the rest of the cell. Maybe if I turn off, I'm turning off the light. See, I can still open that. So there is a dark pink line at the very top. That is the brush border. So that's where the microvilli are. That's where the enzymes, brush border enzymes, will be released. Keep the light off or on?
Please.
Okay.
People voted off, so
Let's do half.
there we go.
But that would be that brush border. Functions of the small intestine include digestion of nutrients. So we just talked about the brush border enzymes doing the final breaking down. We also have the pancreatic enzymes doing some breakdown, and bile emulsifying fat. We'll have mechanical breakdown happening here via segmentation. So this is the back and forth movement of the food in between the walls of the GI tract. It's going to contract and relax in front and behind the food in order to break it down into smaller pieces. We'll also have absorption of almost all of our nutrients. So most of our nutrient absorption happens here at the small intestine. Almost all of our water, about 90% of the water that we absorb, is absorbed at the small intestine. Propulsion, which is moving food forward. And propulsion is going to push food, or at this point, chyme/feces, depending on where it becomes solid. But it's going to be pushing that food all the way through the small intestine and all the way through the ileocecal valve, where the small and the large intestine meet up. So any questions on these functions? Okay. And the propulsion is going to happen through peristalsis, which is just moving food forward. All right, the large intestine. There is a kind of a flow chart in your lecture notes, a blank flow chart that starts with the cecum with attached appendix. So we have the cecum with the attached appendix first. After that, it flows through ileum is going to be attached. Don't put the ileum there. but that's just where we enter the cecum here. But then we go to the ascending colon. So it's only going to be the ones in pink that you fill in. Ascending colon to the transverse colon, to the descending colon, to the sigmoid colon, to the rectum, and then to the anal canal. Now, these are highlighted here because the ileum is the last part of the small intestine. It's going to meet up with the cecum, and it's going to release chyme or feces through this ileocecal valve, which is right around here. But the ones in pink are for your flow chart. Now you should be aware of all of the other structures of the large intestine. We have the haustra. Now this is only pointing to a single one. So a single one is a haustrum. If we're talking about multiple, it's haustra. So the haustra are these normal little pockets within the large intestine that help move food along. And then we have points where the large intestine or the colon changes directions. We call those flexures. You can call them the right and left colic flexure, colic meaning related to the colon, or you can name them for the major organs that are nearby. So on the liver side, we call it the hepatic flexure on the right, and then on the left where the spleen is, we call it the splenic flexure. So you're free to call it either one, whichever one you're more comfortable with or would remember better. So it's up to you which you call it. And then we have the transverse mesocolon, which is one of our mesenteries that are going to suspend the large intestine, or in this case, the transverse colon in place, as well as act as a passageway for vessels and nerves. And it's going to help with some storage of fat as well. So questions about those? Okay. Hemorrhoids. Hemorrhoids occur through, and this I think is already in your lecture notes, it's failure or damaged valves. And so when that happens, when the valves fail and they can't move the blood forward properly, you have the pooling of blood. So blood ends up gathering in that damaged vein area, and it distends the vein or stretches the vein larger than it should be because the blood just pools or stays in that area. That pooling leads to varices or varicosities. You can call it either one. But those, we talked about varicose veins. So you can have varicose veins in your legs from that same reason, damage to valve, pooling of blood in the legs because you're standing for too long or sitting for too long. This can happen at the anus as well. And so when this happens in the anal veins, then we call them hemorrhoids. Now, I want to also talk to you about two sets of sphincters that we have here in the anus. So we have an internal anal sphincter, which is made up of smooth muscle. And so would that be voluntary or involuntary? Involuntary. But then we have the external anal sphincter, and that's made from skeletal muscle. So is that voluntary or involuntary? Voluntary. So what we're going to talk about in a couple of slides is the defecation reflex. So the defecation reflex will relax the internal anal sphincter so that feces can move down towards the opening. But then it is you that controls your external anal sphincter that will allow for the release of those feces during a bowel movement. So when you potty train a toddler, you're really teaching them how to use and control that external anal sphincter. So we do have a model in the classroom that you probably saw on the day of the digestive anatomy lab, where it does show, those hemorrhoids. And you can have external hemorrhoids as well as internal hemorrhoids. So they can be both external and internal. So they can be caused by constipation or forcing your bowel movements. You shouldn't have to force your bowel movements. By forcing them, you're causing more pressure in that area, which is more likely to damage those valves or cause those valves to fail, and the blood pools and then the veins distend. Can also be caused by childbirth as well. Childbirth definitely will cause hemorrhoids as well for the same reason. It just causes a lot of pressure in that canal, which then causes the valves to fail, and then the blood ends up filling up those veins and causing them to stretch. So internal and external hemorrhoids. So mesenteries. Ooh. We have the greater omentum, which you identified during the digestive anatomy lab. The transverse mesocolon behind the transverse colon. The mesentery or mesentery proper that holds the small intestines and the first part of the large intestine together. So today, when you get to the pig today, if you pick up the small intestines and kind of stretch them out, you can see that sheet or the mesentery that holds them all together. Don't be grossed out, Bianca. But you definitely can. I don't believe the sigmoid mesocolon was on your learn list, was it? The sigmoid mesocolon? If it is, it's just attached to the sigmoid colon, but I don't think it is on your learn list. All right, so don't forget, greater omentum is that flap on the front of the intestines on the torso model. So most of our fat storage is subcutaneous. And I think, is this already in your lecture notes? Okay. So underneath the skin, if you remember, the subcutaneous layer, when you talked about the integumentary system, is not part of the skin. It's just the epidermis and the dermis. But males, they hold their abdominal or visceral fat right there at the greater omentum, which is why men have more belly fat. So right there at the greater omentum is where their fat will accumulate. Females, though, are in their hips, thighs, buttocks, and breasts, except when they are post-menopause. So during menopause, estrogen levels drop, and so the fat storage goes from those feminine areas to the belly. Because it's estrogen that's driving the fat to those, again, feminine areas. All right, so make sure you know, not lesser omentum. You need to know the greater omentum, the mesentery, and transverse mesocolon, and then, of course, your serous membrane as well. All right. So bacterial flora. So the flora or the bacteria within your large intestines are going to do the final breaking down of any food that's left. And so they cause the release of vitamin B that can be absorbed at the large intestine. They cause the release of vitamin K from the food that we eat that can be absorbed at the large intestine, and also some nutrients. So most of our nutrient absorption is going to happen at the small intestine, but your bacteria can actually further release some vitamins that can be absorbed by the large intestine. Now, when bacteria break down things and eat away at things and allow the release of these vitamins and other nutrients, they also release wastes in the form of gas. And so that's what can make you like flatulent and fart and things like that. And so if you are particularly gassy and you let one rip, just tells people it's your bacteria, it's not you. So this is one of the reasons why people who are like lactose intolerant get a lot of gas, because it's not getting properly broken down in the small intestine where it should. So then that dairy moves on, or that sugar, the lactose moves on to the large intestine, where bacteria love sugar. And so that bacteria will eat away at the sugar, causing that gas, and the gas fills up your intestines, which can cause a lot of cramping and bloating and discomfort.
So there's cancer.
Yeah. Yes, sir.
What would happen if you held your gas for like a whole time?
It's just going to cause more discomfort because that you're not releasing that pressure or releasing that gas. Digestive processes in the large intestine. So some vitamin and water absorption. The last 10% of your water absorption happens at the large intestine. Propulsion of food forward through peristalsis. Defecation, though, is the primary function. So we're going to talk about the defecation reflex next. And so how the defecation reflex works is that the feces move into the rectum and they stretch the rectum. Stretching the rectum, and what kind of receptors are going to detect that stretching? What do we call stretch receptors? Mechanoreceptors. So those mechanoreceptors or stretch receptors are going to detect the feces moving into the rectum, and that's going to send a signal to the central nervous system, which is then going to send another signal down to tell the colon to keep contracting and moving things forward, and as well telling the internal anal sphincter to relax. Okay, so a spinal reflex is initiated in which parasympathetic motor fibers stimulate contraction of the rectum and sigmoid colon and relaxation of that internal anal sphincter. So if it's not an appropriate or convenient time for you to have a bowel movement at that time and you hold it, then contraction is going to stop and those signals stop. However, your GI tract's still moving around, still doing stuff. So as soon as more feces move into that rectum, the signal gets sent again, the internal anal sphincter relaxes, and you get that urge to go again. Okay? If still it's not time, contractions will stop until more food moves in. Now, there's only so much pressure that your sphincters can hold. So at some point, you're going to lose control, and it's going to happen whether you like it or not. But it does stop. So you have some control. So if you ignore it, contractions stop. But as food keeps moving in, you're going to keep getting those signals. Okay? So if it is convenient to defecate, or if your body can't handle it anymore, voluntary motor neurons are inhibited, so it's going to allow those skeletal muscle sphincters to relax, and so the feces are then going to pass. Any questions? Okay. It's so fun talking about pooping. A clinical note is an ileostomy. So because most of our digestion and absorption happens in the small intestine, we don't need our large intestine to live. Okay? And so you can live after a complete removal of the large intestine. This process is called an ileostomy. Why it's called an ileostomy? We're not talking about the removal of the large intestine. We're talking about taking the last part of the small intestine, which is the ileum, and reverting it to the front of the abdomen. So we cut off the large intestine. Sometimes we leave some parts behind, sometimes we don't, and I'll show you that picture next. So sometimes they'll leave the rectum behind. Sometimes they remove everything completely. It depends on your condition. Usually it's removed due to cancer. So if you have a cancerous large intestine, then they'll remove the large intestine depending on how far along it is. They can either leave the rectum behind or not. But the procedure is all about taking that last part of the small intestine, the ileum, and now repositioning it to the front of the abdomen so that then you can move your feces through a colostomy bag. So an external pouch on the outside that needs to be regularly changed. Okay.
The large intestine is removed completely, and then the small one is just kind of stretched to...
No, it's just taken from where it is and just put into the front of the body. So it's not a very long distance, but they reconnect it to the front of the abdomen so that you'll have a port with a colostomy bag, and then the feces will move into the bag. So obviously lifestyle adaptations will be necessary. You'll have to learn how to live with a colostomy bag, and how to change it and all of that. You are going to have to uptake your water or increase your intake of water, because now you're losing that last 10% of water absorption from the large intestine, so you have to make up for it. So you have to just bring in more water than a person with a large intestine has to. So any questions about that? Yes, ma'am.
There's no you have no control over that, right? Because it's just moving out of your body.
Yeah. Mm-hmm. So any questions on that? Okay.
How does the, because I take care of it, how does the skin around it not become infected so easily?
That I don't know. Let me look into that, because I've never had that question asked of me before, but I will. Let me.
They have to clean it every time, because the bag can only stay on for like about a week. And they have to remove it, and then they wash and clean it with soap and water.
No, they have to put a new bag.
Well, yeah, because like before they put it in the bag, you wash and clean the skin, because
It's
the skin,
sterilized.
because it's gonna get the acid from the stomach, all the gas
Yeah.
content.
Yeah.
So they periodically, I think like every 7 days, you have to change it, clean it.
How do you keep it dry so it doesn't get infected?
No, they have to put a towel, because we have some patients, they have a cluster bag, they put a towel to clean it down. And they have special kind of towel, they don't use a fabric one, because the threads go in, they have a threads go inside. So the nurse do it, like she used the towel, cover it first, and then she have some special equipments to clean it down inside. Then she have to put a new bag inside, then and start doing the same process every 3 or 4 days. Because the bag starts smelling so strong, you can't tolerate that smell inside the room.
And also too, like the bag, you measure the diameter of the stoma. They call it a stoma.
The stoma.
And then you measure it, and then there's a special adhesive that they have to use that's like
Tape.
so it'll stick to your skin, also not cause it to leak out.
Yeah.
But that has to get, again, it's every 4 to 7 days, just depending on how bad they go.
Yeah.
How's
How
your
frequent,
feces?
yeah.
How frequently you go?
Yeah. Well, there you go. It's why it's good to have like
And then it just
clinical
depends
people here in the
where
class.
stoma's at, like how far in the intestine, like if it's like right at the beginning of the small intestine, it's gonna be a lot of runny.
Oh yeah, because it doesn't
it's
move
a
through
walk.
the entire
If it's
thing.
towards the end of it, then obviously you'll get more chunks.
Yeah.
Bowels.
Yeah. See, my education is limited to biology, so it's always good to have people out in the field. All right, so here's a Bristol stool chart. So this is like the range of what your stool can look like. It's so fun talking about poop. I get all these weird faces when we talk about poop. But now the sweet spot would probably be around 3 or 4, type 3 or 4 on this Bristol stool chart. Once you get to about 5 to 7, this is where it's going to be diarrhea. And what's happening is that the contents of your intestine moves too fast through your intestines, and so you're not getting enough water absorption. And so if you're not getting enough water absorption, lots of fluids still stay in your intestines, and you end up having watery stools. This can be due to changes. It's a lot of times due to changes in your flora. So like if you take antibiotics and your bacterial flora gets rearranged, then you're not getting proper breakdown of food. Also, your body's not used to it. So if your body experiences a change, then your GI motility is going to increase and things are going to be moving through fast. And again, if it moves through fast, then you're not getting enough water reabsorption or water absorption from the food that you eat or from the stuff that's moving through your intestines. And so your stool doesn't get solid because you're not absorbing enough water because it's moving too fast. It doesn't give the cells enough time to absorb that water. Also, if you were to eat something that irritates you, so like food poisoning. So let's say you eat something that's not prepared well. Your body knows that it doesn't belong there and knows that it's an irritant. So again, it's going to try to move things through as fast as it can so that it's no longer in the body. And when that happens, you're not absorbing enough water. The feces doesn't become solid, and so you end up with watery stool. Constipation is going to be over here, like 1 and 2. Constipation is because the opposite. This is because the contents in the intestine moves too slow, and now you're absorbing too much water, and so the feces become too hard. So this can be due to a lack of fiber. Fiber is what is going to keep your feces moving along at a good pace. So if you lack fiber in your diet, it's going to slow down the movement of your food through your intestines. And so that gives the cells too much time to absorb water, and they absorb too much and the feces become hard. This can be due to a lack of water as well. If you're dehydrated, then you're not going to be able to absorb enough water, and it's going to end up being hard. Also, exercise. Exercise keeps your GI tract moving at a good pace as well. So if you're not exercising enough, you're not getting enough GI tract motility, things are going to be moving too slowly, and you're going to absorb too much water, and the feces end up hard to pass. Also, if you abuse laxatives, after a while, you're going to lose GI tract motility, because if you're abusing laxatives and your food is just moving through you really fast because you're trying to lose weight or something like that, then your GI tract stops responding. It stops working the way that it should. You lose motility. And so when you're not using those laxatives, you're going to have constipation. Also, by holding your bowel movements as well. If you hold your feces for too long, again, your body's going to start like going to sleep, essentially. Like, it's not going to work as well as it should if you keep ignoring those signals. So if you're constantly ignoring those signals and not getting that GI tract motility, then it's all going to start to slow down, which can also lead to constipation. Questions about those?
So you're good if you're at 3 or 4, huh?
3 or 4. That's a sweet spot. So gross. All right, so diverticulosis versus diverticulitis. Diverticulosis is just a condition of having or experiencing diverticula. So diverticula are both, and this is abnormal. So we talked about like the haustra that make up the anatomy of the large intestine. Those are completely normal. These diverticula are an abnormal bulging of those pouches. This is a bulging pouch that form when weak portions of colon give in to pressure. Now, diverticula is plural. A single one is a diverticulum. Causes of these diverticula include lack of fiber or a high-fat diet, and we'll talk about how that occurs. Lack of exercise, so you don't get enough GI motility. Aging. Over half of the population that's over 70 will experience diverticula. Obesity. Also, obesity can cause changes in your gut flora, which cause changes in your GI tract motility, which can lead to these diverticula. Also, smoking as well. So how smoking can cause GI tract changes is because, now things that are real evident with smoking, so smoking dehydrates your skin, right? So you'll notice that people who smoke cigarettes, their skin looks a lot more aged more quickly than others. But smoking not only dehydrates your skin, it's dehydrating all your organs as well. And so your GI tract wall ends up being weaker than somebody who's not a smoker, and so more likely to give to pressure and cause these pouches throughout the GI tract. So we only see the skin, but it's causing all kinds of internal damage as well.
Like if we have surgery and you're a smoker, tissue takes forever to repair.
Oh yeah, yeah.
Because if they're not getting oxygen to those tissues.
Yeah, so those who are listening to the recording, Molly brought up that when people who are smokers get surgery, tissue healing is a lot slower because of the lack of oxygen getting to those tissues. So we mentioned that people who smoke get like 15% less oxygen delivery than everyone else. So oxygen is very much necessary for healing. Now, those pouches, they can become infected, they can become inflamed, which leads to diverticulitis. Okay? And diverticulitis, those pouches, when they become red and inflamed and irritated and infected, they can actually rupture. So with diverticulitis, these pouches may rupture. And when they rupture, they're going to release feces and bacteria all throughout the peritoneal cavity, which is going to cause what that we talked about 2 lectures ago? Before sepsis.
Infection.
What is it?
Infection.
Well, yes, but what is it going to cause irritation of if it's being released into the peritoneal cavity? Peritonitis. Okay, so it may rupture, which is going to lead to, to peritonitis. And if that bacteria that gets leaked into the peritoneal cavity due to the rupturing of these diverticula, if that bacteria spreads, then it can eventually lead to sepsis. But it starts with peritonitis.
So peritonitis is when there's already all kinds of feces and stuff in there, and it's already all bad?
Yeah.
That leads to that.
Yes. So I did say that I was going to explain how lack of fiber can cause this. So when you don't have enough fiber in your diet, your large intestine doesn't stretch as much as it should, like it would if you did have fiber in your diet. So your colon volume ends up being smaller, so you have less stuff moving through your colon. And so over time, because you're not using up that space, your colon's going to narrow. And as we talked about with Boyle's law, a decrease in volume means an increase in pressure. So if because you're not filling up your large intestine enough and it narrows, those contractions that happen within the colon are now stronger and cause more pressure in this smaller container. Okay? And that's going to make those pouches or those diverticula more likely. Smaller volume, more pressure from the contractions. And so you cause more of these little pouches that form due to the increase in pressure. Does that make sense? Okay. So this is diverticulosis. So that's what you're looking at here, diverticulosis. So diverticulosis is just a condition of having those pouches. They're not infected, they're not inflamed, they just have given into the pressure. And so you have these little pouches within the GI tract. When it turns into diverticulitis, they look more like this, where you have lots of inflammation and swelling that occurs due to the irritation or inflammation. You don't want your GI tract to look like that. Here's what it looks like from the outside, diverticulitis. So again, lots of inflammation and redness and swelling due to the infection of those diverticula.
So I was just gonna say that.
Why is he what?
I have no gloves on.
Bye.
He does. They're clear gloves. You know, you can see now they're gloves. They are. He's wearing gloves. Yeah. Yeah, no, they're clear. Imagine. All right. So the diverticula are outward pouches that occur, but then you can also have, oh wait, before we get there. This model is one that you should have seen last time too. I'll bring it out again today so you can see. But you have the diverticula here, or that would be considered diverticulosis, having those. But then on the inside, you can see inflamed ones that have like bacteria or swelling redness. That would be diverticulitis. So if I tag it from the outside, I'll most likely ask you for the condition of having those pouches, and you would say diverticulosis. But the inflammation and redness from within that you see on this model is diverticulitis. The yellow on this model are bacterial infections. The little tiny brown growths here, people sometimes think it's poop. It's not poop. Those are polyps. But then they can also grow into cancer, which we're going to talk about next. Oh, you can also see appendicitis on this model as well. So diverticula are outward growths. Polyps are inward growths. Okay, so again, diverticula are outward. I wouldn't say growths, but they're outward pouches due to the increase in pressure. Okay, but colon polyps are an inward growth. They grow from the inside towards the lumen. And so these are mostly harmless. You just need to get regular screenings and have them removed regularly, because if they're left untreated, then they can eventually develop and grow into cancer. So you can see here different stages of those polyps, but then you start to get abnormal cell growth, and then it can form and become malignant and become an invasive cancer. Okay.
Do you have any information on cysticercosis?
No. We can look it up together and talk about it. But again, mostly colon polyps are harmless. Again, you just need regular screenings and removals for these. Risk factors, you're more likely to develop polyps if you're over the age of 50. I guess, I don't know if these are in your lecture notes, but I'll write it down. Over the age of, are they in your lecture notes for polyps?
Starting at age of 45.
Oh, that's for a colonoscopy, right? For 45. So the risk factors for having colon polyps, though, is if you're over 50, being overweight. Again, if you're a smoker. And then if you have a family history of polyps, you may be more likely to develop them. And so prevention, again, is just regular screening and removal of these polyps before they can grow and form into cancer. Now this next image looks like this person's not wearing a glove, which I don't recommend. But you can check for these polyps through a rectal exam. So a physician would just put their digits through the rectum and look around and check for those polyps. But definitely should be gloved. It does look glossy, so maybe he's wearing a clear glove. Yeah.
So you guys kind of know either.
Yeah, probably gloved.
He's gloved.
Okay.
Draw the image of a glove.
True.
Make the hand blue.
Right? So colonoscopy is where, well, first of all, you'll drink a nice, yummy drink the day before to clear out all the contents of your large intestine and your GI tract in general. And then they will take an endoscope, and they're going to retrograde up the rectum and anus and through your colon and take a camera to take a look at what's growing or not growing or what's present in there. It's routine after the age of 45, and then you're recommended to get every 10 years. Although if you do have a family history of colon cancer, things like that, you should be doing that more often. It used to be age 50, but in recent years, like in the last 5 years, they've lowered it down to 45 because of the increased incidence of colon cancer. So now they suggest 45. Yeah. I'll probably get it more age of 40 because colon cancer does run in the women in my family. You can lower your risk by having adequate calcium in your diet, by exercise, which keeps your GI tract motility up, fiber as well, which again is going to keep things moving at a nice pace. Aspirin is known to decrease inflammation, so less inflammation, less damage, less growth, and so less likely to form cancer. Also, research shows that aspirin actually increases immune activity as well, so your immune cells will be more likely to detect cancer sooner. Polyp removal, and then decreasing your dietary saturated fats and dietary preserved meats like deli meats and stuff. You're more likely to have or develop colon cancer with preserved meats. So like hot dogs and deli meats. Huh?
I don't like hot dogs.
You don't like hot dogs?
They also have the home kit you can take home, the ice.
Oh yeah, where you can do a sample. Yeah. All right, where are we at? Oh, we have time. So we're going to talk about how each nutrient is processed, how it turns into its monomer, and then is absorbed by the capillaries at the small intestine. So a little bit of biochemistry here. So for starches and carbohydrates, those get broken down into smaller sugar chains. I'm not going to ask you about oligosaccharides, but they're just smaller sugar chains. And disaccharides, those are broken down through salivary amylase and pancreatic amylase. And then these are disaccharides here. Those are going to get further broken down by those brush border enzymes that I mentioned that do the final breaking down. And those break down into monosaccharides, which all three of these here are monosaccharides down here. But we're going to talk about this whole process individually. So this is your diagrams version of this. So here are longer sugar chains. They're broken down by some pancreatic amylase into these double sugar chains here. And then we have brush border enzymes, which are these guys here that are going to break those, no, just kidding, not those. Brush border enzymes are on the microvilli, sorry. Then we have these brush border enzymes here that are going to do the final breaking down of these double sugars into single sugars. Now, only the single sugars can be brought into the cells. Only monomers can be brought into the cells. So after they're in their monomeric form, they can be brought into the cell. So these are all single sugars. And then from there, they're transported across what's called the basolateral membrane of the cell into the interstitial space and then eventually into the capillary. So this is your book's description of it. We're going to run through. There is a simpler diagram of it in your lecture notes and then a blank space underneath for you to write it out yourself. So I'm going to tell you right now that on your next exam, I'm probably going to ask you to do this pathway either for carbohydrates or proteins or fats. So we're going to do it together. So we have polysaccharides. Which are going to get broken down into disaccharides. And this is through our amylases. And at this point, because we're at the small intestine, it's going to be specifically your pancreatic amylase. So make sure that you know that it comes from the pancreas. Then it gets broken down from disaccharides into monosaccharides. And it's brush border enzymes that do that. Once it's a monosaccharide, now it's a monomer, and it can be brought into the simple columnar cells of the digestive tract. Those simple columnar cells, and those are my little microvilli, those simple columnar cells, those are called enterocytes. And so now these monosaccharides can be brought into the enterocytes, and it's brought in through active transport. And what is that going to require? ATP. And then when it moves into the capillary, it's going to move this way, same thing as a monosaccharide. It's going to move out of the cell through facilitated diffusion. And what does facilitated diffusion require? A protein to move it across. And then finally, that can diffuse, and this is going to be simple diffusion because it's just going to move through the spaces of the capillary. And then saccharides in the capillary. Now, there are many different monosaccharides. So the main ones, we'll go back. You guys were still, you wrote down? Or where?
I wrote it down.
We can look at
Okay, we'll go back to the video so I don't have to draw it out because we only got 7 more minutes. One thing I do want to tell you though, and you have it right above where we were drawing it to, yeah. So the liver. So what is the main sugar that we use? The main monosaccharide that we use for making ATP and such? Glucose. Glucose is our main monosaccharide. This is the one that our body uses. Okay, but we get other monosaccharides from our diet. So the liver converts non-glucose monosaccharides like galactose or fructose into glucose. So glucose is a sugar that our body likes to use. So if we get any other monosaccharides from our diet, our liver is just going to convert that into glucose. So then our body can use it to make ATP. So this is carbohydrate digestion. Where does carbohydrate digestion begin in the body? In the mouth. Through what enzyme? Amylase, salivary amylase. Everybody good here? Okay. The next one is protein. So we're going to talk about protein digestion. This is your book's diagram of it, but we're going to do our own. So polypeptides or proteins are going to get broken down into large protein fragments. And this is going to be done through pepsin. Where does pepsin come from?
Chief cell.
The
Chief cell?
Oh yes, chief cell, sorry. That come from which organ? Stomach. Yes. So one thing though, before pepsin works, the hydrochloric acid that we produce in the stomach, it actually denatures the proteins. Do you guys remember talking about denaturing like in B32? So it basically like unravels the protein folding, which makes it easier for the pepsin to break it down. Yeah. And so we have pepsin that makes it into large protein fragments, and then we make it into smaller protein fragments. Through trypsin, which comes from the pancreas, as well as other proteases. And then we finally break it down into its amino acid form through those brush border enzymes. And then from there, it's exactly like it was with the carbohydrates. Ooh. I'm going to put it over here because I ran out of room. So the amino acids are going to be brought into the enterocyte through active transport. And then transported over the basolateral membrane at the bottom here through facilitated diffusion. And then by simple diffusion, they will move into the capillary. So then we'll have amino acids in the capillary. So questions on that process?
For the hydrochloride, right by the pepsin,
Uh-huh.
what is it? Oh, it denatures them.
It denatures the protein. So it unravels the protein folding, so it makes it easier for pepsin to start breaking down that protein. Everyone good here? Okay, last one is fats, because we're actually not going to focus on nucleic acids because they have very little to do with nutrition. Okay, so lipids is our last one. So with lipids, we have large fat globules. This get broken down into fat droplets. What is the chemical that emulsifies fat? BIOL. So this happens via emulsification. And then we turn those fat droplets into fatty acids and glycerol. And when it's a single glycerol, they're called monoglycerides. And I think that's in your lecture notes. And that's done by lipases. So lipases are what breaks down those lipids into its parts. And then from there, the fatty acids and glycerol are repackaged with bile salts to make something called a micelle. So, like micellar water also uses micelles to break apart the fatty bits of your makeup so that's easier to clean off. Okay, now micelles, those are brought into that enterocyte through simple diffusion. Because remember, things that are fat soluble can diffuse over easily. Okay, and so within the enterocyte, what's going to happen is the micelles are going to join up with protein, and those are going to be converted into something called a chylomicron. So now it has protein attached. So now it's not going to be able to move by simple diffusion because it's no longer just fat, it's fat and protein. So then it exits through that enterocyte, the chylomicrons do, through now exocytosis. And then they're going to move into the lacteal. So make sure that you know that inside the lacteal, I couldn't draw the lacteal that big, but inside the lacteal would be a chylomicron. So one of those three pathways you're going to have to know very well for the exam. You don't know which one, so just know them all very well. Everybody good here? Yeah.
If you learn the books way too?
Yeah. Your book's going to have a lot more detail than what I'm going to require of you on the exam. So this would be like the minimum you need to know for the exam. But definitely you can use the book's explanation as well, especially if you're going to go into something like nutrition. You're going to want to know more details about it. Really quickly, though, before you pack up, for nucleic acids, all you need to know that it's nucleases that break those down into its parts and eventually into nucleotides. That's kind of explained already in your lecture notes. And then the last very bit about absorption of vitamins, electrolytes, and water. Know that fat-soluble vitamins like A, D, E, and K are absorbed. Fat-soluble vitamins you can overdose on because those get stored. Where do they get stored? Where? Liver. It's the liver. They get stored in your liver, so you can overdose on those. Water-soluble vitamins, though, like C and B, those get excreted through your urine if you have extra. Remember that one of those vitamin Bs is vitamin B12, which needs intrinsic factor in order for you to absorb that vitamin B12 from your diet in order to make mature red blood cells. Water, know that 90% is absorbed in the small intestine, 10% in the large intestine. Iron and calcium. Iron absorption needs ferritin. Remember, we store iron as ferritin in the mucous membrane. And then in order to absorb calcium, we need vitamin D. And vitamin D that process is only activated by UV rays from the sun. And that's it. Now you can pack up.